So some things that I want to look at specifically today is being able to help everyone distinguish between the procedures, because there are quite a few, and there are benefits and risks that vary amongst them. And also looking at how, as a provider, you can provide some support with long-term follow-up. And then I know insurance was a big question, so we'll touch on that as well at the end. So I wanted to look at procedures just in a generic view here. So there are some more non-traditional type procedures that are done endoscopically, they're not quite as widespread or as popular. There's a few different endoscopic procedures. The gastric balloon was approved several years ago, and there's some different versions of that, and the gastroplasty as well. So I'll touch on those in more detail, but the other ones listed here, transpyloric bulb, aspiration therapy, and the VPOC, I can tell you I've actually never seen these done, and so won't really touch on those quite as much. And then on the right-hand side, we have our more traditional laparoscopic procedures that we perform more commonly, like the gastric band, the sleeve gastrectomy, the Roux-en-Y gastric bypass, and the duodenal switch. So we'll look at those in more depth. Next slide. So this is going to be those more non-traditional procedures here. So on the left side, we have a gastric balloon. And so the way it works is the surgeon goes in endoscopically, inserts a gastric balloon, and it's filled with saline. And so it takes up space. So it's more of a restrictive type procedure. Now, this is only approved to stay in for a maximum of 6 months, and then it has to come out. With the endoscopic sleeve gastroplasty, I don't see a lot of surgeons performing this. I was lucky enough several years ago to work with a surgeon that was one of the first 25 in the nation to start performing these. And so again, they go in endoscopically, and they use an endostitch to suture the stomach. And so it creates that sleeve-like shape without it being a permanent removal. And so they have that restrictive capabilities there as well. And traditionally, these are indicated for, you can go to the next slide, that's good. Traditionally, these are indicated for lower BMI. They're less invasive, but they also have less weight loss. They are restrictive, not necessarily permanent. And typically they're done on an outpatient basis. So that's appealing to a lot of patients as well. And so for this, I guess I should have done more of like pros and cons of it versus risks. These are not covered by insurance. So it can be very, very costly for a patient to pay completely out of pocket for this. Typically, we're looking at upwards of $8,000 for any of these procedures. We do see a lower weight loss, which is why it is approved for lower BMIs, typically of a BMI between 27 and 35. And with some of those with a foreign body like the balloons, we have seen instances of obstruction or perforation. And we have to be careful as far as not placing it in any person where it's contraindicated. I'm sure y'all are aware there was a big case with one of the balloons several years ago in Louisiana where it was placed on a physician actually that had a prior Nissen, which is contraindicated, and he ended up unfortunately dying from this. We also early on had some balloons that had a valve defect, and so bacteria actually was able to get in and caused air to expand the balloons and cause an obstruction, and so I did see we had to remove one of those emergently. Next slide. Gastric band, lovely pictures I have in here for everyone. Next slide. I'm sure most people are relatively familiar with the adjustable gastric band. These were super popular. We don't place a ton of them anymore nationwide, but occasionally we will. I actually saw a young lady, she was 23 yesterday, had a band placed. So some benefits of it is that it is restrictive. So we see some modest weight loss with that, not quite as much as we see with some of our more invasive procedures. Something that does appeal to people is that it's reversible and flexible, so very adjustable. You know, unfortunately though too, we see if a patient is planning a trip, they may go into their surgeon's office and say, hey, I want to be able to eat whatever I want. Can you remove some of my saline out of my band? So we do still see some yo-yoing, but we've had patients do phenomenal with it. They really enjoy it. We do see less risk of malnutrition. There are still some supplements required, but since we're seeing more of a modest weight loss, not quite as much restriction, they're not as at risk. Things that we do see risk-wise, we see a good amount of reflux in these patients, especially years out. And it is a foreign body, and so we can see some issues as far as it slipping out of its proper placement, causing obstruction or eroding into the stomach. Can cause some esophageal dilation, can have some port site issues, and out of the metabolic and bariatric procedures, this is where we see the highest reoperation rate. Next slide. Sleeve gastrectomy is represented here, and so this is the most common procedure that's performed, and its popularity has really skyrocketed in the last quite a few years. Medicare started approving coverage for this, I think it was about 2013-ish, somewhere around there, and so we've seen these numbers go up. So the way this works is it is completely irreversible. We go in and remove about 75 to 85% of the stomach, and so the patient is left with a sleeve-shaped stomach, and the pyloric sphincter is preserved. Oftentimes I see, especially in ER provider notes, that they'll put patient had a sleeve placed. There's no foreign body with this, so nothing being placed. Next slide. So benefits of this, it is a restrictive procedure, so patients can consume a lot smaller amount. But what we've seen with this is that the removal of the majority of that fundus of the stomach decreases the production of the hunger hormone ghrelin. So patients also experience less of an appetite. There's no foreign body, and we see a good amount of excess weight come off in those 2 years right after surgery. It has a very low complication rate. Typically, we see better outcomes with this versus a chole. However, it is irreversible. Our other procedures are all pretty reversible, but this one is not. And as we can see with any sort of surgical procedure, we may have issues such as a leak, bleed, surgical site infections, DVT, PE. Up to 30% of patients with a sleeve gastrectomy do have some reflux. And so typically we can manage that medically and avoid any trigger foods, but occasionally they may have to have a revision to a bypass or another procedure. And then malnutrition. I do find oftentimes people think, since this is not a malabsorptive procedure, that these patients are not at risk for malnutrition, but that is a complete fallacy. They are physically unable to consume enough nutrients from their food, and these patients have to take the same vitamin and mineral supplementation for life as they would with a gastric bypass. So that's very important. And then this is the Roux-en-Y gastric bypass. It's not the best visual representation, but just go with me on it. And so the way this works is the surgeon goes in and dissects the stomach, creates a smaller stomach pouch at the base of the esophagus. The remainder of the stomach stays in there, so it does still produce the gastric enzymes. But we bypass about the first 150 centimeters of the small intestine to create some malabsorption. And then it all reconnects a little bit lower in the intestines. So it works in that we are restricting and we have a smaller stomach capacity, about the size of an egg, and then also from the malabsorption component. So we've got the restrictive and malabsorptive components. We actually do see improvements in blood glucose control in this versus the sleeve or the band, likely due to some of those hormonal changes and the malabsorption. We see an increase in satiety. And this is really good for patients that already have issues with reflux, particularly if they've had a diagnosis of Barrett's esophagus, because the sleeve would be contraindicated in that patient population. And we also have done this not even from a weight loss perspective, but diabetes-wise, if a patient has gastroparesis, this is very beneficial because it increases that gastric transit time. We see up to 80% of patients' excess weight come off in those first 2 years following surgery. And again, there's no foreign body. It does have a slightly higher complication rate than a sleeve, not by much. And some risks particular to this procedure would be marginal ulcer. So we definitely caution patients on avoiding long-term NSAID use. We may see bowel obstruction, dumping syndrome, which the majority of the time is going to be directly tethered to food choices. So counseling patients on avoiding concentrated sweets and high-fat items that would trigger that. And actually that ends up being a big motivator for a lot of patients in choosing this procedures because they need that reinforcement to make some lifestyle changes as well. We also occasionally will see postprandial hypoglycemia, and that's somewhere else where a dietitian can come into play as far as creating balanced meals and snacks with these patients and not having just concentrated carbohydrates and making sure that they're having a healthy balance of some protein or heart healthy fats to prevent that from occurring. Next slide. Sorry, guys. My spectra. Okay, the DS, this is becoming more and more popular here. We're seeing a good amount of these, and there's different variations on it, but overall, it's kind of a combination of the sleeve and the bypass. So they go in, and sometimes it's staged. Sometimes they'll do a sleeve first, and then they'll go in and do the bypass type version. So go in and do the sleeve. So we've got that decreased stomach capacity, decrease in the hunger hormone ghrelin. And then we actually bypass about twice as much of the small intestine as we do with the gastric bypass. So a lot more malabsorption here. These patients do have to have additional supplementation, especially the fat-soluble vitamins, A, D, E, and K. And since it is much more invasive, this is actually reserved for patients that fall into the super obese category, so a BMI of over 50. Next slide. Benefits are, we do see a much more significant amount of weight loss here. We have the restrictive and the malabsorptive components, and so we see pretty much all of the benefits of both the sleeve and the bypass. With the blood glucose control, reflux, gastroparesis, satiety, but we also see the same risks as we would in those two other procedures. So especially the malnutrition, we're gonna really, really focus on close observation of those labs and making sure they're taking all of the appropriate vitamins and minerals. So as a provider who may come across patients with any one of these procedures, whether it's fresh post-op or 20 years down the line, you know, what is your role? Where do you need to step in? We definitely encourage lifetime follow-up with their surgical team, whether it's seeing the surgeon or someone in their office, their dietitian, behavioral health, offering those support groups, which every accredited center does have. All of that is very, very important. Ensure that they are taking vitamin and mineral supplementation. And so when they come into your office, they may say, oh, well, I'm just taking some over-the-counter vitamins. Make sure that those are recorded in their med rec. And adjust medications as needed, especially during that rapid weight loss. You may have to keep a closer eye on things like blood sugars and tweak their medications far more often. And also look at things like if they're on something like Jardiance or anything in that class. We have seen some patients with euglycemic DKA come in, so something to be aware of as well. Oftentimes, patients may not be able to follow up long-term with their surgical team. It may get costly for them to pay that specialty copay. And so you may end up having to absorb some of the follow-up care. So checking labs, especially in that first year, we want those checked every 3 months, typically then every 6 months for that second year, and then at least annually for life. And so on the next slide, I have a list of the labs that we need to keep an eye on. It's pretty extensive. Oftentimes, I know everyone runs into issues as far as insurance picking these up. Medicare, a lot of times, will kick it back, but especially after they've had surgery, there is a code or a series of codes directly tethered to these procedures as far as malabsorption and that sort of thing that typically pick them up. Next slide. So you may have patients that you think would be good candidates for surgery, but don't really know where to begin. Don't hesitate to reach out and send a referral. I know insurance is a big hang-up and people have a lot of questions about that, and oftentimes that will stop them from seeking additional information. But I guarantee you, no matter what office you send this patient to, they've got someone in their office that this is their full-time job, is to check those insurance benefits. I know for my hospital in particular, we have a whole website where the patient can go in and submit their information, and it's very easy. We've got someone that calls and gets them a referral to a physician's clinic within the system that takes their particular insurance. As I said earlier, Medicare does provide coverage now. Some state Medicaid plans do as well. And then commercial plans vary tremendously. I definitely cannot make any sort of blanket statement that, yes, Aetna, Blue Cross, Cigna, United, all cover it. It's going to be very, very policy dependent. So let that surgeon's office take care of that, because even if there is not coverage, there may be financing options or something else. Like I know we're getting more and more towards our pricing transparency and creating these cash bundling prices that have some promotional financing available, care credit, that sort of thing. So definitely it's worth sending that referral, letting that patient have a conversation and see what is feasible for them. Generally speaking, if they do have insurance coverage for obesity or for metabolic surgery, qualifiers would be a BMI of 40 or greater, or 35 or greater with comorbidities. That too is very insurance dependent. Type 2 diabetes across the board is going to be a qualifier. Sleep apnea. Hypertension, sometimes there is one particular insurance company that says the patient will qualify if they are on 3 different antihypertensives and still uncontrolled. Then we'll count it. But if it's just hypertension, they're on 1 or 2 meds, or 3 and they're controlled, we're not going to cover it. But another thing is these surgeons' offices are very well versed in how to negotiate, do peer-to-peers, get this type of thing overturned. And some of these procedures too can be done specifically for reflux, and so it may even be exploring that option versus for the obesity diagnosis. Surgery should never be the first option. We will always screen and make sure patients have tried other methods to lose weight, or at least that the risks of not pursuing surgery far outweigh the benefits of waiting to try and do some non-surgical weight loss. Next slide. So I do have a couple of resources here from our accrediting body, ASMBS. So it will be able to find a provider in the area for your patients at an accredited center. And then there is some coverage information too, if patients are interested, at obesitycoverage.com, where they can kind of at least get somewhat of a baseline of information while they're waiting on their specific verification. And these are my references. And any questions?